Bismillahirrahmanirrahim. Hi, everyone. I don't know if you read it before or not, but the American Heart Association and American Stroke Association just released some guidelines regarding the early management of patients with acute ischemic stroke. So I thought to make a quick video about it, highlighting the stuff that's probably more relevant to acute medicine or hospital medicine, and think that hospitalists need to be aware of. It's kind of interesting guidelines, so I'm just going to go through it really quick. And of course, one of the important principles they mention in the guidelines is the ischemic stroke mimics things that can look like stroke, but they're not a stroke. And the most important one is hypoglycemia or severe hyperglycemia sometimes. So that's one of the reasons why it's always important to test blood glucose before calling it a stroke. And then, of course, complicated migraine sometimes can look like stroke, so they want you to be aware of the things that can make migraine more likely, like younger age, prior episodes, slower progressive negative symptoms like blindness or numbness or tingling, presence of aura, variable or fluctuating exam, and headache. And post-ictal phase, sometimes people after seizure, they might seem to have like a focal neurological deficit mimicking stroke. Conversion disorder, of course, but it's always diagnosed with seclusion. And absolutely, the mimics is shown in the brain imaging, and that's the reason the scan of the head is always done in a management of these patients before you call it stroke, to check for like bleeding, hemorrhagic strokes, subdural hematomas, or arachnoid hemorrhage, brain masses, brain tumors, this kind of. So some of the tests that the guidelines talked about, and this is probably more relevant in the emergency medicine or emergency department, but as hospitalists, we go there all the time. And with new patients, and sometimes patients have like symptoms suspicious of a stroke while they are admitted in the floor for something else. So it's useful for hospitalists to know this as well. So of course, we talked about the importance of checking the blood glucose at the point of care, a coagulation test, and intravenous thrombolytics should not be delayed while waiting for the results of, for example, platelets in the CBC or INR and all that. But again, you need to order this test if you're like the clinical scenario suggested that the patient might have bleeding risk for any of the reasons. For example, patient is taken anticoagulation, for example. And then some cardiac tests also, like EKG and troponin. So baseline assessment is recommended, and it can affect the prognosis as well. But again, the guidelines clearly stated that you should not wait for the results of these, to delay the acute management of patient with a stroke. And then renal function is the same thing. You're probably going to need to order some contrast imaging for your patients, and not having a renal function should not really delay getting these images if time is important factor in the management of the patient based on the clinical scenario. So these tests, most of these tests will be done in the emergency department, and they're available for the hospitalist to look at and base his or her clinical judgment accordingly. Again, back to glucose. Patient with diabetes, there's strong recommendation that, again, checking the point of care glucose before calling it a stroke, to make sure that the blood glucose is not less than 60 milligram per deciliter. And there is also a strong negative recommendation, or like no benefit, really strictly control their blood glucose to a level between 80 or 130 or less than 140. You should aim for a target of 140 to 180, because this is hasn't shown to improve the 3 months of outcomes, and can be harmful and can lead to hypoglycemia down the road as well. So that's something that's worth mentioning. So what are the options for imaging that hospitalist has to evaluate patient with, let's say, acute onset of stroke in the floor while being admitted for something? So obviously the non-contrast CT scan or MRI, but most of the centers will go with the non-contrast CT scan, and it's a strong recommendation. This is the one required to kind of assess ischemic burden and to exclude intracranial hemorrhage. And this ideally should be done within 25 minutes hospital arrival. That's also a very strong recommendation. And then in patient where large vessel occlusion is suspected, then you can get some imaging with contrast, like a CTA or MRA of the cervical and extracranial vessels, to wait if the patient really has indication for endovascular thrombectomy. And then the extended window, this is something that is kind of relatively new now. This is based on some of the recent trials and data, like the Wake Up trial, the Extend trial. If you remember, we used to have the 0 to 3 hours. That's a definitive benefit. And then there's extended time for 4.5 hours. And now the extended time is 4.5 to 9 hours. So for these patients, this is particularly when a patient has onset of a stroke that is unknown. Or, for example, the classic example is the wake-up stroke, right? The patient was well before going to bed, and then they woke up in the morning with right-sided weakness. So that we don't know exactly when the stroke happened, and many of these patients were excluded because by the time they excluded from intravenous thrombolytics, because by the time they get to the hospital, it's most likely more outside of the window. But now these patients has options by doing this imaging, like MRI or CT perfusion or MR perfusion, to look for the penumbra and look for the extension of the ischemia to give an idea about the duration and acuity of the onset of ischemia or stroke, so that we can, treat it still with intravenous thrombolytic because of the benefit of intravenous thrombolytic. So that's kind of new here. I think that's probably one of the bigger things in the guidelines in my perspective. So what usually happens, and again, it depends on your institution. A lot of times there's the bundled orders. So patient, when they get it into the emergency department and they're like, cause stroke is activated, this patient will get non-contrast CT scan of the head. They will get a CT angiogram, and they'll get a CT perfusion at the same time. And it's important that these tests should not really delay treatment, specifically intravenous thrombolytics. That's really key here. So if the institution can build a protocol around getting these 3 tests together, that would be nice if they can do it efficiently. And then they can make a decision about the use of thrombolytic based on the results of these. So that's especially, again, for the group where the onset of stroke is unknown, or they can fit into the acute treatment with intravenous thrombolytic if they are still within the 4.5 to 9 hour window. And even better, I don't know about your program, but mine, unfortunately, we don't have that. But I think probably some hospitals, they have the CT scanner bolus strategy. When the patient goes in the CT machine, they get screened for hemorrhage, and when the hemorrhage is excluded, they get the CTA and CTP. But the radiologist will decide that the patient doesn't have any contraindications for intravenous thrombolytic by having a mass or intraventricular, like subarachnoid hemorrhage or something. And then the call can proceed with IV thrombolytics. So this is called the CT scanner bolus strategy. Very, very cool if you have it, but again, you have to really be familiar with the protocol that your hospital adopts. So an important recommendation that is still present, of course, is assessment severity of the stroke. And this is a stroke recommendation, and the most commonly scale used is usually the NIH-SS. So it's still recommended to have some form of assessment of severity, but again, this is the one that's usually used. And a very important concept here is really try to assess the severity of the stroke because it affects the decision about the intravenous thrombolytics. Usually an NIH-SS of 5 to 15 is considered like moderate stroke in terms of severity. But an important concept that people need to be aware of is the concept of disabling symptoms, because a lot of the benefit of the intravenous thrombolytic is really stemming out from the fact that it's given for a patient with disabling symptoms. So it's not just about the number, it's about how bad the symptoms are and how it's affecting the patient. So for example, a patient who cannot talk anymore because of the stroke, who cannot see anymore, who cannot use their dominant hand anymore, who cannot stand or ambulate because of ataxia anymore after the stroke, or any deficit that's really substantial for the particular patient because of their job or occupation, for example, that's considered disabling symptoms. And even with an NIH stroke scale less than 5, they still can consider treatment. So I think that's really important to know. But there's a lot of advantages of having the scaling system, and it's still highly recommended that people do it if they're evaluating a patient with acute stroke. Another important aspect that just, as a hospital, just to be aware of it is the ASPECT, which stands for Alberta Stroke Program Early CT Scoring System. Alberta is basically a city in Canada where this was developed. So basically, this is a score assigned by the CT scan or by the radiologist, and it's really kind of also in the line of the severity scale. It also gives some idea from the radiology perspective about the extent of the ischemia and the core of the stroke or the infarction. So it depends on which area you're looking at, and the radiologist will look into certain areas and they try to figure out if there is any certain indications or radiological evidence that the ischemia is extended beyond a certain point. These signs include something like bleeding of the gray-white matter interface, hypodensity or darkening of the brain tissue, or a sulcal effacement or smoothing of the brain fold or swelling or anything like that. These might get that there is ischemia present. And for example, in MCA stroke, certain areas that I will show you soon, for example, if the score, all these areas is 10 out of 10, that might indicate that it's a normal scan and there's no visible ischemic changes in these assessed regions. So maybe the disability is expected to be really small in these patients. At the other end, if it's below 6 or below, that might indicate like a large stroke core. And this, just like a very high NIHS, it might indicate like a really higher risk for hemorrhagic conversion after intervention. So the best is having a score of our aspects of 7 to 9. This indicates a relatively smaller stroke core, which is basically the irreversibly damaged tissue, and this is generally favorable for intervention. And this is what I'm talking about. So for example, here in the CT scan in the MCA territories, there's another aspect for the posterior circulation territories, and this is the 10 areas, and they have like -1 or something for certain areas, and they just calculate the number, and they look for these signs we talked about in these areas to come up with the aspects number, and because this also can help decide about the severity of the ischemia and whether the intravenous thrombolytic would be a good option or not. So all this is done. Why, of course, is really to come up with a big decision about whether intravenous thrombolytic therapy should be given or not, right? So the recommendation is to give the IVT for disabling deficit. We talked about that, regardless of the NIH stroke score. And if the patient presents within the 4.5 hours, and the agents in the new guidelines is still like tenecteplase or alteplase. So whatever is really available in your institution, that would be the one to go with. And there's certain dose for the tenecteplase that's not recommended, the 0.4 milligram per kilogram. And this is just stating the same thing here. So again, within the 4.5 hours, if the patient came in with acute ischemic stroke, we did not evaluate the patient, ischemic disabling symptoms, no contraindications, or relative contraindications can be handled, then again, one of these two agents should be given. Tenecteplase or tenecteplase, whatever is available. Again, there's no recommendation to give dose that was tested in trials and didn't show any benefit. And this is kind of maybe relatively new for these guidelines. It's really kind of the extended window, right? It's a class 2A recommendation is that patient who awake with the stroke symptoms within 9 hours from the midpoint of sleep, or between the 4.5 and 9 hours from the last known well. So again, this is probably mostly for patients who had the wake up stroke, right? So let's assume that a patient went to bed at 10 p.m. and then he woke up at 6 a.m. and he had a stroke. He woke up with a stroke, so we don't know when the stroke happened. It's anytime between 10 p.m. the night before and 6 a.m. in the morning. So this is about like 8 hours. So the midpoint of that is 4 hours, and that would be 2 a.m. So in that patient, when let's say they present to the ED right away at 7 a.m., so the time of stroke would be assumed, or the midpoint would be at 2 a.m. So between 2 a.m. and 7 a.m. when the patient presented to the ED, that's about five hours. So in that case, the patient is still eligible to get the IVT, even if it's like up to 9 hours from the midpoint of a sleep. Then the patient will still be eligible if, again, they have disabling symptoms and they meet the perfusion criteria or the imaging criteria that we talked about earlier. This is the patient that you want to get the CT perfusion or the MR perfusion to kind of look at the penumbra and the core of the infarction to see if the patient might benefit from IVT or not. So this is kind of the relatively new, and it's kind of interesting principle. So an important concept for the hospitalist to know is this concept of cerebral microbleeds. So cerebral microbleeds, or CMBs, these are characterized by a small chronic deposit of iron-rich blood breakdown products like hemosiderin, and are clinical indicators of a small vessel pathology. They can occur anywhere in the brain. For example, the deep CMBs can be found in the basal ganglia, the thalamus, the brainstem, the brainstem and might indicate hypertensive arteriopathy, and the low Bs might indicate cerebral amyloid angiopathy. They're usually detected by MRI, specifically the T2 weighted gradient recalled echo or the GRE MRI, or the susceptibility weighted imaging or SWI. This is kind of really reliable in detecting those. And why these are important? Because you might, if seen, they do not necessarily exclude patients from getting intravenous thrombolytic, especially if they're like few in numbers. So if they are less than 10, again, you can still give intravenous thrombolytic, and this is class 2A recommendation. But if the patient had more Bs, like more than 10, then this might indicate like the high burden of these Bs, and the neurologist will decide at that time if the intravenous thrombolytic is beneficial or not. So this is just important to note that for me as a hospitalist, when I see this in my mind, it like excludes IVT right away. But no, the presence of a small microbleeds, that does not exclude the use of intravenous thrombolytics according to these guidelines if they're like few number less than 10. Another concept to know, which I found also interesting in this table, sometimes you are faced with some clinical scenarios where you really don't know if intravenous thrombolytic are indicated or not. And of course, again, where you work, you have a protocol for that. You have the neurologist help you out. But I think for hospitalists, it's really cool to know all those things so that you have an idea what's being done and what's going on with your patient. So, for example, in patient we talked about stroke mimics. If your stroke is still consideration, probably the benefit is more than the risk for intravenous thrombolytic, and you probably still need to treat. If the patient had a history of GI bleed beyond a 3-week period, then you still can consider intravenous thrombolytics. And of course, some of the conditions where like clearly the patient or the patient team should avoid using intravenous thrombolytic, as some of these well-known conditions to some people. So I think it's just really useful to kind of go through this table really quick and to have some idea that, about what could be kind of a relative contraindication or where the benefit is not really large enough to justify the use of intravenous thrombolytics. Now, a very important and relevant aspect of acute management of stroke is, of course, the blood pressure target for these patients, right? As you probably know that if the patient is eligible for intravenous thrombolytic IVT, then and they have very high blood pressure, the recommendation is to try to get it down to below 185 over 110 to avoid complications like bleeding. And this is before giving the IVT. So after giving the IVT, you have to maintain the blood pressure below that as well, specifically less than 180 over 105 for at least the first 24 hours. And this is one of the reasons that's believed probably in all hospitals, but definitely for the hospitals I worked in. These patients, after IVT, they go to the intensive care unit for 24 hours for monitoring, close monitoring. And this is one of the reasons, because they can treat high blood pressure with IV blood pressure medications. Now, assuming that the patient is not eligible for IVT and they get admitted to the floor to your service, within the first 2 or 3 days, if the blood pressure is high, but it's not as high as 220 over 120, still below 220 over 120, usually you can allow that to happen. If the patient doesn't have any evidence of in-organ damage, it's okay in the first 2 to 3 days. If it's really very high, treatment benefit is really uncertain if it's more than 220 over 120, but you can consider, reducing the blood pressure to, about 50% reduction degree kind of thing. This is class 2B recommendation. If the patient ended up having endovascular thrombectomy, avoid very low blood pressure, because hypoperfusion can worsen the situation and can make the stroke worse, or can lead to another hypoperfusion or ischemic stroke. And this is like kind of a negative class recommendation kind of thing. So you should target for a blood pressure of less than 180 over 105, just like the patient who get the IVT. And then, of course, when the patient is ready for discharge, the target blood pressure will be individualized based on the patient comorbidities and secondary prevention target and strategies based on guidelines. So yeah, I think this is probably a helpful table for hospitalists to be aware of. So let's talk about endovascular thrombectomy, EVT. I think this is really important for residents and hospitalists to know the criteria so that they know when their patient will need them, these interventions. And if they have it in the hospital, that's good. But if not, they need to know the criteria because they will initiate the transfer. Again, that's if the patient is already in the floor, or for example, if the hospitalist is asked to admit a patient from the ED, whether that patient get IVT or not, they should know whether this patient meet the criteria for EVT. Of course, again, we talked about having a neurologist on board. Most likely they can help you with that as well, but I think it's still useful to know the criteria. And mostly when we talk about EVT, we talk about large vessel occlusion, and these large vessels include internal carotid artery, middle cerebral artery, especially the M1 segment, and sometimes the proximal M2 segment as well, the vertebral artery, specifically the intracranial segment, especially if it's a dominant artery, or the other contralateral vertebral artery is small. Basilar artery is also considered large vessel, but we're going to talk about that soon. So what are the criteria? What are the benefit? The green ones are the one that has the most benefit, has class 1 indications for EVT. So these patients, when we talk about large vessel occlusion seen in the CTA, when the CTA was done initially, and the patient present within the 6 hours of onset of symptoms, and the patient has a disability or disabling symptoms, so to speak. And the aspects, we talked about the aspects. The aspect is core favoring less large ischemic changes seen in the CT scan, with aspect being 6 to 10 or 3 to 5. And the patient has a pre-stroke modified Rankin score of 0 to 1. These are the patients who are like perifunctional before the onset of stroke. These are the patients who get going to benefit the most. Now, a patient was modified a Rankin score of 2 or 3 to 4, they benefit the less, but they still can be considered case by case. So these are one of the criteria to consider AVT. If the patient presents a little bit late, between 6 and 24 hours from the onset of symptoms or onset of the stroke, they still have disabling symptoms with the NIH stroke score of 6 or more. And the aspect score also still favorable between 6 and 10 or 3 or 5 also can be still considered. And also they have a modified Rankin score of 0 to 1. This patient also will benefit from EVT, and it's a class 1 indication. Now, with the basilar artery, the criteria is up to 24 hours since the onset of symptoms, and they have an aspect of core. This is a little bit different for posterior circulation, but it's still favoring less ischemic changes seen in the CT scan, and they have disabling symptoms with an NIH stroke scale of 10 or more, and the modified Rankin score is 0 to 1, meaning they're perifunctional before the onset of symptoms. These are the patients who will benefit also the most from EVT. Now, if they have less disabling symptoms, it still could be considered case by case. What about medium vessel occlusion? These are, for example, the N2 or second segment of the middle cerebral artery. So these also can be considered if they present within 6 hours and within 0 to 6 hours, and they have aspect of 6 to 10, and they're also pre-stroke modified Rankin score is 0 to 1, also can be considered based on a case-by-case evaluation, and with the help of the neurologist and the stroke team. So this is generally indications for EVT in the acute management of stroke. Now, how about going over the clinical scenario that's kind of relatively common, just to kind of explain what we talked about so far. So if we have a 68-year-old man, history of hypertension, diabetes, CKD, and atrial fibrillation on apixaban, he goes to bed around 10 p.m. neurologically intact after taking his scheduled evening dose of apixaban at 9 p.m. He awakens at 7 a.m. in the morning with right-sided weakness and difficulty speaking. He arrives at the emergency department an hour later, around 8 a.m. On examination, his NIH stroke scale score was 14, notable for dense right hemiparesis, facial droop, global aphasia, and right-sided neglect. As you can clearly appreciate a disabling symptoms here. Non-contrast head CT scan showed no hemorrhage, with an aspect of 8, which is also favorable, and CT perfusion demonstrates small lymphatic core with a substantial area of hyperperfused but salvageable tissue. So we really want to target that salvageable tissue, right? CTA reveals that here patient had acute left M1 middle cerebral artery occlusion. So the first question is the patient has indication to get intravenous thrombolytics? So he has disabling symptoms. That's quite obvious. What about the time? So basically, the last known well was around 10 a.m. and then he woke up at 7 a.m. with the symptoms. So he had like 9 hours. And we don't know exactly in these 9 hours when he had the stroke. So we use the midpoint, which would be around 4.5 hours. So that would be 2:30 a.m. 2:30 a.m. He has 9 hours from that. That would be 11 a.m. So if he present before 11 a.m. and he did, because he present 8 a.m. and he had disabling symptoms and he had a favorable imaging, indicate that he might benefit from IVT, which is the case here, because the CT perfusion really had a large salvageable area of ischemia and penumbra. So he will benefit from IVT, but the problem is he had what looks like a contraindication. Within 48 hours, he had actually taken his apixaban, and he had actually had a CKD too, so he might even need more time. So if it's not for that, he would have indication for IVT, but because of that, apixaban he's like probably the harm and risk of bleeding outweigh the benefit. So generally speaking, if a patient had taken more than 48 hours ago and the patient had normal kidney function, it's reasonable to consider IVT, but unfortunately it's not the case for this patient. He had taken it within less than 48 hours. So it's generally considered contraindication. Again, it's case by case, I think. For diabetic arthritis, has a little bit of a special situation. You can consider IVT if you reverse the agent and it's taken within less than 48 hours. More than 48 hours, normal kidney function maybe can be given. And another aspect, which is not really practical, if you can measure the activity of the DUAC, and it's to be in the lower, like the amount of the drug is really small, then you can also consider it. But again, that's really not practical because most of these tests take some time for them to come back. The second question is, what about endovascular thrombectomy? Is it indicated? So patient had what looks like really all the criteria to have a consideration for AVT. And if you don't have an AVT capability center in your hospital, then you need to transfer the patient. It's an M1 middle cerebral artery occlusion, and it's disabling symptoms. It's within the 24-hour window. So patient is really can potentially benefit from AVT, so consider sending this patient to endovascular thrombectomy. How about inpatient stroke care unit? Yes, it's very helpful to have that, and it should really improve outcome. So clearly, a lot of hospitals now have like a really dedicated stroke unit, hopefully. But yeah, if you have that, that's really the best for the patient because of a lot of advantages that you can see here. How about consultation with a neurologist? We talked about that. It's usually also kind of a class 1 indication. And, again, most of the hospitals will have like a dedicated team, including a neurologist on board as well. And having a standardized admission template and protocols done by the hospitalist or the intensivist, if the patient is going to the intensive care unit, is also a class 1 indication because it showed that it's improved the outcome, and it also makes sure that all the orders, necessary orders are followed and nothing really being missed. So regarding antiplatelet therapy, the recommendations stay the same about the using of dual antiplatelet therapy with clopidogrel and aspirin for 21 days in patient with minor non-cardioembolic acute ischemic stroke or high-risk TIA with an ABCD2 score of 4 or more. If the patient did not receive intravenous thrombolytics and they have presumed atherosclerotic cause with like more than 50% of stenosis of intracranial or extracranial stenosis that was likely to have accounted for clinical presentation or acute neuroinfarction on imaging of presumed large artery atherosclerotic origin. So basically, atherosclerotic disease should usually benefit from dual antiplatelet therapy if they meet this criteria, and then after that they can be continued on a single antiplatelet agent. Also, anticoagulation, for example, if a patient has atrial fibrillation and developed ischemic stroke, when to start anticoagulation? This is very common and challenging question for hospitalists and neurologists in general in the words of stroke. And there is a class 1B recommendation that maybe in carefully selected patient, starting anticoagulation a little bit earlier might be low risk, and safe in many patients. Select it carefully. Generally, I personally used to like the 1, 3, 6, 12-day rule from the 2013 European Heart Rhythm Association guidance. So you can start anticoagulation in the first day after TIA if there's no infarct or hemorrhagic on imaging. You can start it on day 3 after a minor stroke. You can start it on day 6 after a moderate stroke. And you can start it at day 12 after a severe stroke. That's based on the NIH stroke scale. But honestly, with all this new data coming in, I think maybe at one day we can talk about the 1, 2, 3, 4-day rule. So it's probably maybe the better. So we'll see how that goes on. For DVT prophylaxis, I think it remained largely similar. So patients who really do not like ambulating and have no mobility issues, probably it's not recommended. But patients who had like impaired mobility and there's no contraindication to use of intermittent pneumatic compression devices, IPC, these patients should get it. This is a class 1 indication. You can also use DVT prophylaxis if there is no, again, high risk of bleeding or like, thrombocytopenia or something like that. And they also still have impaired mobility. And there's, of course, like a negative indication or recommendation for like elastic compression stockings, and they can cause harm, so you should not use them. The same thing for swallow screening. Bedside swallow screening is important, and a lot of the hospitals, they have the nurses do that. And then if there's any concern, it's always a good idea to get a speech pathologist to examine the patient and even consider endoscopic examination. The last thing I want to talk about is assessing the patient for depression. The timing of screening is uncertain. As hospitals, we should do that in the first few days after stroke and start treatment is not really known, but definitely it's a class 1 recommendation to screen patients after stroke for post-stroke depression, maybe during the first visit or second visit to the primary care doctor, and also a class 1 recommendation to treat with antidepressant or non-pharmacological interventions like psychotherapy, if indicated and if the screening is positive. I think we tend to not to think about that quite often, but again, timing is uncertain. I don't know if I should put my patient on antidepressant 4 or 5 days. If the screening is positive, it's not really known, but keep that in mind. So yeah, I hope these points that we talked about are useful, and hopefully this video made the understanding of the concept of the new guidelines, the 2026 guidelines, much easier for you. Thank you very much, and let me know if you have any comments. Thank you.